Good evening. I hope everyone's in a place that's safe and warm. Obviously, it's been an interesting start to another year in a pandemic, and we're prepared to talk a little bit about, how or if that might impact fertility care in the coming future. But most importantly, tonight we wanted to start with kind of a basic understanding of what is involved in creating a fertility plan, admittedly with more of a focus on IVF, but we're also able to talk about some of the related topics aside from IVF, if that's what people find helpful as well. So this first slide is just showing you our team of physicians, and the reality is you could think of a physician in an IVF team as being kind of like the head coach on a football team, and the reality is that they're the person that's sort of calling all the shots, but really success is the result of a combination of many different people that are also very important. So we've got a wonderful team of mid-level providers as well as a tremendous group of nurses and ultrasonographers and medical assistants, and even reception and billing people are all really geared towards participating and making things very geared towards each individual patient couple. So please don't take the five of us as acting like we're the ones that are really the result of the success or failures. We're just the ones that are kind of leading the individual care of each patient couple. So next slide. And that's me. I'm the weirdy beardy guy that I got 26 years experience. I've worked at some of the top fertility centers in California. I've also worked in New York before coming to the local Colorado market. And the reality is I brought a lot of experience with me, not just the way we do things here, but it's given me a lot of insights into a lot of the ways that other people do things as well. And I'm happy to share that with people as well, both on an individual basis when I'm talking to individual patients, but also in an open forum like this. So next slide, please. So the purpose of this diagram is to make the point that we are not the most fertile species on the planet. If you look at the diagram to the left, that's the 1 month estimated pregnancy rate for a very fertile woman at age 25 or age 30 or at age 35 or 40. And the point of this slide is that on a monthly basis, it's very easy to remember that even a very fertile patient at age 25 doing everything right at home has about a 25% chance of being successful. And we used to wonder why the natural fertility rate was so low, but we've actually learned from our egg donors that tend to be patients in that 23 to 27 year age range. And one of the things that we've learned is even the very best egg donors, that if you have 6 to 8 eggs from an egg donor, that's usually enough to produce one baby and sometimes two and very rarely three. So the point of that is that even the most fertile woman at age 25, is only, there's only about a 1 out of 3 to 5 chance that any given egg is going to be a good egg. And since women are naturally only releasing 1 egg a month, you could imagine that a month that somebody is not releasing a good egg, they're not going to get pregnant. And that's why the diagram on the right of this screen shows that we diagnose fertility problems as anyone that's falling out of the realm of not being successful within 1 year of not using contraception. In other words, the way human biology is adapted to our low per month pregnancy rate is that if someone doesn't get pregnant this month, they could try next month or the month after. And you could see that within 1 year, even in the ideal fertility range, people have about an 80% chance of conceiving within a year. And you'll see in a moment, that's why we define fertility problems on, if people are falling outside certain realms within certain given time periods. The other point I like to make using this slide is if you look at how the 1 month fertility rate falls between age 25 and age 30 versus 35 or 40, a lot of people assume the natural pregnancy rate is falling because a woman has fewer eggs as she's getting older. But that also is a misperception, because someone that's fertile at age 40 is also releasing 1 egg a month, just like someone that's fertile at age 35 or 25. So what's really changing over time is the chance that any 1 egg is going to be a good egg to begin with. So that's the second concept, is that fertility rates change over time because of natural changes in egg quality with the eggs that a woman has left. So I know that's a lot of content for one slide, but let's go on to the next slide and we'll draw those points out in more detail. So you could see that the definition of infertility is for someone that is not using contraceptive if they're under age 35 for 1 year, because we would assume that within 1 year, if everything was ideal, that someone would have conceived, and preferably more than once, under age 35. Now, at age over 35, we actually say that we should start to do an evaluation if someone is not conceived within 6 months, because of the known and measurable effects that are expected to occur in everybody related to egg quality. The other point is that for people over 35, especially if they want to have more than one child, it's important to start doing an evaluation early. Keep in mind, an evaluation does not mean someone needs to actually seek treatment, but it's your way of trying to determine, are you as fertile as the average person the same age, or more fertile or less fertile? And how is that going to impact what you want to consider trying naturally versus with treatment? Next slide, please. So what this point is making here is looking at the basics of the menstrual cycle. And, the menstrual cycle, which is that, on average, 28-day period of time that exists between the beginning of one menstrual period and the beginning of the next. And we break that down to within 3 different ranges within that menstrual cycle. And, the point is the follicular phase is the point in the cycle when the eggs are competing, because there's a group of eggs at the beginning of the menstrual cycle that are competing to be picked for that particular month. They're kind of competing with one another, trying to see which one, might naturally be the best. Okay. And typically, through a process of competition hormonally, 1 egg is selected so that phase 2, or ovulation, is when that egg that's selected for that month is most fertile and is actually being released. And that's what some people refer to as the fertile window if you're using ovulation prediction kits, because that's the point where the egg in a natural cycle has been selected and is available to be fertilized. One of the other important points is all the other eggs that were competing for that month, they start to immediately undergo a process of being reabsorbed by the body. Those eggs can't wait for the next month. So each month, a woman loses a group of eggs that are competing, and naturally 1 or occasionally 2 are naturally be selected for release, and you lose the rest of that group. The third phase is what's called the luteal phase, and this is the preparation of the uterus, that if it was a good egg on that month, and if that egg did meet up with a good sperm, this is preparing the uterine environment for implantation. And that's what the luteal phase is about. And some women worry that, maybe their progesterone level is low and maybe that's the problem. But that's also something we've learned over the years is a misperception, because if a progesterone level is low, it's not because the ovary is not capable of making enough progesterone, but it typically means that the egg that was released was not a healthy egg to begin with. And that's why giving progesterone to someone because they have a low progesterone level is not going to boost their fertility if the problem was with the egg, because again, that means that it occurred in the earlier phase of that particular, menstrual cycle, phase 2 versus phase 3. Next slide, please. So back to the basics of what does it take to create a successful pregnancy. On any given month, you need to have the following things happen. Number one, it's got to be a good egg. If it's not going to be a good egg that month, it's not going to happen. Number two, that egg is only good for a limited period of time of about 36 hours. So if that egg is not exposed to sperm in that period of time of 36 hours, that month is a done deal, even if it was a good egg. Then the next thing that's important is if the sperm that meets up with that egg is not a healthy sperm, you could fail on that month, not because of timing and not because of an egg, but sometimes a bad sperm can enter the egg or not be able to enter an egg if it's a good sperm, that can also result in failure for that month. The last thing that has to take place on that month is successful implantation and development. And if it's a great egg and a great sperm and it fertilizes, but it doesn't make it to the uterus, or it makes it to the uterus at the wrong time, or makes it to the uterus at the right time but can't implant, it's still not going to be successful. And that's why the natural fertility rate is as low as it is. And what we try to do with the IVF process is to control each and every one of these variables independently to create the most predictable outcome, even from one group of menstrual cycle, one group of eggs that we're competing. So next slide, please. So, one of the things that's important is whenever we start a basic fertility evaluation, what we're assessing are those 4 different aspects of fertility. Is someone capable, or do we believe they're capable of producing fertilizable eggs? Does their partner have sperm that we believe is capable of actually fertilizing an egg? Are there fallopian tubes, or at least is one fallopian tube open so the sperm and egg can actually physically meet with each other? And does the person have a uterus that seems to be able to support implantation? And so the basic fertility evaluation is looking at these 4 aspects and also trying to see if there are some particular problems that might be more commonly associated. And some examples that are listed here are endometriosis, primary ovarian insufficiency, male factor, or PCOS, or what I call, in the 6th bulleted point, social fertility problems. These are if someone is either in a single person or in a same-sex relationship where they can't fulfill all 4 of these criteria on their own. And then sometimes what we find out is we rule out all the most common abnormalities, and someone is classified as a diagnosis of unexplained infertility. And I want to talk about that for just a moment, because I know that can drive people crazy. And unfortunately, what it really means is, in my opinion, it's a poor choice of words. Because for people that have unexplained infertility, we know they have infertility based on the amount of time they've not been using contraception. But the word unexplained, in my opinion, should be replaced by the word unspecified, because again, it's only a single word change, but it's a very different impression. The unexplained kind of makes it sound to people like we don't know what's going on. Whereas unspecified means we know what's going on, that there's infertility, we've ruled out certain causes, and of all the remaining things that might be contributing factors, here's what your treatment options are and how much they can boost your odds above trying naturally. So unspecified infertility, I think, is a much more empowering term than unexplained. Next slide, please. So the basic fertility evaluation is geared towards assessing a woman's potential ability to producing eggs. and also trying to assess where she's at on the basic, assessment of how that compares to other women. And this can be very, very important because, for instance, if someone even appears very fertile, but they're 40 or 41 years of age, if that person wants to potentially have 2 children or 2 pregnancies, you could imagine that even if they're able to successfully conceive naturally for the first one, they might find that they're not able to have a second child. So that's why we always try to, order the test to get an idea of what any one woman's individual timeline is, so that they can not only create a plan that's going to optimize their chance of having one successful pregnancy. But if someone's all-time goal is to have more than one, we got to be thinking about that second pregnancy even before we create the first one. And then we use certain imaging studies to try to assess the woman's anatomy to see, again, whether her fallopian tubes are open and whether we see any reason anatomically that we think her uterus might not be able to support and sustain a pregnancy. Next slide, please. So the next issue that's so important is doing a basic assessment of the man. And I explain to the guys all the time that if you look at the research studies with couples that have fertility problems, 30 to 40% of the time, the guy is a contributing factor. And so even if a woman has a diagnosis of PCOS or endometriosis, or even something more obvious like a tubal ligation, there's also possibly a contributing factor from the man. And here's the thing that's important to understand as well. Men do not have any symptoms if there's a fertility problem, at least 95 to 98% of the time. With women, we could get a lot of clues by asking things about their menstrual cycle or pelvic pain. Whereas if a guy's got a low sperm count, he doesn't have any symptoms. There's no pain. It does not affect his libido. And that's why we always strongly encourage that a semen analysis should be part of the early and basic evaluation for fertility. So the point of the IVF process is to try to break down the natural barriers into individual steps. Step one, what we call the priming phase, is to try to help a woman, create a group of the healthiest possible eggs that she could make all at one time, so that instead of just being one egg, that there are a bunch of eggs to maximize the chance of having more than one good egg, okay? Step two then is to stimulate as many of those effective eggs to grow as possible, all in one cycle. Step three is to retrieve those eggs and actually look at them under the microscope and see how many are mature and how many appear to be healthy. Step four is then to select one individual sperm and literally inject it inside of each egg to try to maximize the chance that each egg has a fertilizing. And then step five, to observe and see how many of those eggs are able to develop into healthy embryos. And again, this is the first real test we have of egg quality. And so then what we're able to do is freeze those embryos, because especially if someone has more than one embryo, then we prepare the uterus to put in one embryo, or occasionally two if someone really wants to attempt to try to have twins and is safe enough to be able to carry twins, and then leave any extra embryos in the freezer for possible future attempts. So this often helps somebody have 2 or 3 successful pregnancies instead of having to worry about having a pregnancy now and not being fertile at the time that they want to be able to have their next child. Once we freeze an embryo, that embryo remains viable and usable for at least about 15 years after the date that it's frozen. So again, this is a way to help someone not only start a family, but often complete a family, even if they want to have more than one child together. Next slide, please. So again, in doing things in IVF, since we're trying to control each barrier individually, you could also think of it as that each time there's an individual goal and there's several milestones we have to hit. And so in order to do this, we want to, people always ask me, how many times should you do an IVF cycle? In our view, you should try for once, because you do it once, you do it right, and hopefully you even have extra embryos for future attempts. And so in order to split these out and focus on achieving one goal at each phase and only doing it once, the process from beginning the initial consultation to when someone is sent off to their OB late in their first trimester, on average is about a 5 to 6 month gap in time. And again, keep in mind, by the time we say, keep in touch with us and let us know how the pregnancy works out, from that point on, a person still has at least about 30 weeks left in their pregnancy, so more than half a year. And then if someone wants to breastfeed, it's going to delay their ability to have even try to start their next effort to have their next child, by at least a year after they deliver. And so again, when you put that all in perspective, this is why if somebody already has embryos, by the time they're ready to have their next child, you can see they're already halfway through this process, and it's much easier to schedule the next embryo transfer for a sibling for people that want to have more than one child. Next slide, please. So again, the point of this is that an initial consultation, really does require about 1 to 2 months, depending on where the woman is in her menstrual cycle, to complete the initial evaluation. And then by the time of that second visit, we're typically able to say, okay, here's what your natural monthly pregnancy rate would be, and here's 2 or 3 options, and the results of your tests and why we think one option might be better for you versus another, depending on if you want to have one child and be done, or if you want to actually plan on future pregnancies in addition to your first successful one. Next slide. So again, the IVF calendar for people that choose the IVF route, from the moment that someone decides, we do want IVF, if they decide that on the second visit, it takes about 4 to 6 weeks, from that point to get them ready for the egg retrieval as a minimum. And again, sometimes it could be even longer, and we can also delay the process even further if someone has any work-related challenges or travel-related challenges, because part of the benefit of IVF is that we are able to control the natural cycle. So, sometimes, for instance, we deal with a lot of teachers. Sometimes someone says an ideal time for an egg retrieval would be during spring break. Well, then we try to manipulate that person's natural calendar to try to make use of that time period. Next slide, please. Again, once we do the egg retrieval, then we have to wait for several different things. Number one, it takes several weeks for a woman's hormone levels to come back down to normal. One thing that we can talk about a little bit if patients have questions is that, the success rates with a fresh embryo transfer are actually lower today than success rates with frozen transfers. And the reason for that is, at the time of an egg retrieval, a woman's hormone levels are way above their natural levels, which makes the uterus less, inviting to an embryo. So we need to let those hormone levels come back down to normal. Then we need to try to, initiate the process of preparing the uterus to create the ideal window of time for implantation. And so that's the reason for the delay from egg retrieval to frozen embryo transfer. It's also during that time period that we receive the results of genetic testing for people that choose to have the embryos undergo genetic testing. Next slide, please. finally, that was just a brief note about the genetic testing, that we do get the results of the genetic screening during that time frame for people that want to do genetic testing. And so the point is that at the time that someone is actually preparing for an embryo transfer, at that point they know that everything leading up to that point has gone very well. Just to give you some numbers, each embryo that's frozen at the blastocyst stage gives about a 50 to 60% chance of pregnancy. And the risk of miscarriage is more adjusted according to the woman's age. Whereas a person that has an embryo that's gone through genetic testing has a pregnancy rate that's much higher, in the 70 to 80% range, and a miscarriage rate that's much lower than in an untested embryo. We find that the miscarriage rate is below 5%, which is important because a woman that conceives naturally at age 40, for instance, has a miscarriage rate that's roughly around 18 to 20%. And so to have a miscarriage rate that's so much below the natural miscarriage rate, that's another important barrier to a healthy live birth. So at this point, I want to, open things up to some questions. I know Erica has received some questions that people emailed ahead of time, and we could try to work some of those in as well. And if no one has any questions, then hopefully I didn't put anyone to sleep.
And I apologize. I lost the very end of that presentation. I have it. I think that was one of the last slides though. So I think we're good to move on to questions, but technical difficulties, in this age of, I'm sure everyone's used to that with all these Zoom meetings these days. So, but yes, feel free to type into the chat and we can address any questions anyone has. Otherwise, we did get several questions through social media this week. So we can maybe start with one of those while people are kind of thinking of their questions. Let's see. So some of these you kind of addressed, Dr. Greene, but what age are women able to use their own eggs during IVF and transfer?
Highly, highly individualized to each person's situation. I have successfully had patients that were 45 achieve a live birth with their own eggs. Unfortunately, I've had more people in that age range fail. So I know it's possible at age 45. There have also been reported successes in some patients as old as 47. So those things can occur, those outcomes, I should say, can occur. But with increasing age, the chance, when I'm first talking to someone, is adjusted according to their age and their individual history. And so, we allow anyone that has a reasonable chance of having a live birth try with their own eggs. But what's so important is we want people to have realistic expectations up front.
And can you clarify, is that the age of let's say somebody froze their eggs, at a younger age, it's the age of when the egg was frozen versus
exactly
when
the
age
at the
transfer is happening,
egg
correct?
retrieval. Yeah, the person's age at the time of egg retrieval. Because one of the things that we know is that, if a woman freezes, embryos that she made when she's 35 or 39 or 40, even if she doesn't use those embryos until, she's 47 or 48, her success rates remain very, very high, comparable to her same age at the time that those embryos were created.
Okay. All right. So we have a question that came in, and I should have prefaced this a little earlier. So we can't give, specific medical advice. We'll do our best to kind of, give general education. But this particular question, PCOS, turning 40 next month, one unsuccessful IUI, ovulation kits, it sounds like are kind of difficult, not say that this person is not ovulating, which is typical for PCOS, correct?
Exactly. Ovulation prediction kits are not meant for women with PCOS, and many women with PCOS will get a false positive, meaning it'll say they're ovulating, but it'll say that they're ovulating for a long period of time because, what's going on hormonally that's contributing to PCOS can make it incredibly unpredictable. And so those are not, they're not a good tool for women that have PCOS.
So is IVF a success, potentially successful option for this type of patient? And what kind of
Absolutely.
statistics would that, how successful in this
Well,
particular?
PCOS, just to give you a very brief intro into PCOS, and I've got a detailed presentation on this on my blog that you can post as well, talking specifically about PCOS. PCOS is an unusual situation. For instance, for a woman at any age, whether she's 40 or younger, women with PCOS have more eggs competing on any given month, which sounds like a good thing, but there is a greater tendency for the eggs to be of lower quality. And so, for instance, someone at age 40 with PCOS, with an IUI cycle, there's a risk of someone over responding and having too many eggs and being canceled, for an IUI cycle. But in an IVF cycle, we could use the fact that someone's capable of producing more eggs than other women the same age, and more importantly, adjusting the protocol to try to optimize the quality of the eggs. And then if someone does have the benefit of having 5 or 6 or 7 embryos available, we're then able to prevent the risk of multiple pregnancy by freezing the embryos and only putting back 1 or 2. And so, one thing most people don't realize is the vast majority of high order multiple births that they hear when someone has 5 or 6 or like quintuplets or things like that, those women typically have PCOS and their cycles not being managed properly. So in an IVF cycle, we're able to minimize the risk of multiple birth. At the same time, we can maximize the chance of having a healthy initiation of a pregnancy.
Yeah, that's that John and Kate +8, right? That we see on those TLC shows.
I don't know anything about John and Kate, so I can't speak to their individual situation.
Right. Okay. Let's see. How long after removing a polyp do you recommend taking off before transfer?
Yeah. Well, the interesting thing is following polypectomy, there's a window of time where the uterus is more receptive to implantation than if you wait too long. So there's kind of a sweet spot. You generally want to plan on doing an embryo transfer in this window of time of roughly 6 weeks to 3 months after a polypectomy. If you wait longer than that, you lose some of the benefit. And if you do it too soon, the uterus isn't fully healed enough and ready to receive implantation. So for lack of a simpler way to put it, the sticky window of time is ideally roughly about 6 weeks to 4 months or so.
All right. Does using frozen sperm change success rate?
Pretty minimally in most situations. One of the most fascinating things, and I have a great diagram, but I don't really know how to access it, is, the human egg is the largest cell in the body. It's a little bit smaller than a period on a printed page. So you could actually see an egg without a microscope, but just barely. That's what makes it so difficult to freeze an egg, is that egg is chock full of water, all sorts of proteins and all sorts of structures that could be damaged in the freezing process. By contrast, sperm is the smallest cell in the body. It's even smaller than a red blood cell. And that makes it very easy to freeze sperm because there's almost no water inside. There's no protein at all whatsoever. And there's just very tightly compacted DNA. So that makes it very easy to freeze and thaw sperm without damaging it. But by contrast, very difficult to make it possible to freeze and thaw an egg. So sperm can usually be used frozen with no negative impact.
All right. And then this question, I feel like we actually get fairly often regarding birth control use and stopping birth control before start. It's a little it's confusing for our patients because we often use birth control in a lot of our treatment plans
Yep,
to
absolutely.
manipulate cycles and
Yeah.
kind of what you were alluding to before. But is it important to get a regular and predictable period before starting all of this, or can you stop birth control and just get pregnant right away? How does birth control impact?
Well, let me give you just a little bit of historical perspective, because that's where the confusion comes from. With the original birth control pills, women were counseled that they should be off the pill for 3 to 6 months before they try to get pregnant. That was an old idea that was thought to be useful way before there was actually data. It was based on theory. Today, we know that the truth is such an opposite to that. We actually put our egg donors on a birth control pill before we recruit and try to actually, create an egg donor cycle. And the reason we put the egg donors on a birth control pill is it actually improves the number and quality of the eggs that they're capable of producing. So, contrary to the popular myth, most women are more fertile in the first few months that they stop a birth control pill than with time. It's kind of like with the polyp, removal. The longer someone waits after stopping a birth control pill, the more their natural fertility rate goes down. So again, it's just kind of the contrast between an old idea and the newer science and what the data has taught us.
And Dr. Greene, what about that testing, that fertility testing? Does birth control impact the AMH and the FSH? So if you're on, we prefer patients to be off of their birth control method when we're doing that testing?
Yeah, and different tests are different.
Okay.
The AMH it can be influenced by the use of a hormone containing birth control pill, but it doesn't always. And so the point is that if someone wants to do an AMH but has no desire to get pregnant, but just to get a rough idea of where they compare to other women the same age, say someone's 25 and just wants to get a bare basic idea, you could do an AMH test while they're on the birth control pill and know that if they stopped it, it would be at least that good or better. And the point is if somebody is on a birth control pill and has a very low AMH, instead of freaking out, the first thing we say is, use barrier contraception for about 2 months and let's repeat it. And you often find that you repeat it and it's much better, and then you can go back on the contraception and feel much better about it. So sometimes it's knowing how to interpret things and use that information effectively, instead of just allowing yourself to be frightened into or out of any certain thing that they're doing.
Okay. Switching gears a little bit, in general, how many IUI cycles are typically recommended prior to moving on to IVF?
Yeah, and again, this is what the best way to think of an IUI cycle is. What you're doing beyond what you're doing naturally is you're trying to control a bunch of variables, okay? More than you control, by just using an ovulation kit and trying at home. With IVF, we're controlling as many variables as possible, okay? So with an IUI cycle, we know that just like you normally see a gradual decline in fertility if people are trying naturally 6 months versus 9 months. Like for instance, if someone has not used contraception for 6 months, their chance on that 7th and 8th month is not as high as it was during that first month or two they were trying. Okay. Now, what happens is with IUI, you're able to see a much more dramatic decline over the course of a fewer number of months. And so there have been several studies that show that if someone is using ovulation induction IUI and is meeting all the criteria on each one of the attempts, so it doesn't count if someone's cycle was canceled, okay? But if someone completes 3 IUI cycles and met all ideal criteria, studies show that 90 to 95% of successes are going to occur within the first 3 months. That doesn't mean someone can't be successful with a 4th or a 5th or a 6th try, but you should go into those later tries with reduced expectations, because one of the things I talk about every day with patients is trying to normalize the emotional roller coaster that people go through, so that we try to make sure that their expectations, meaning their highs, are appropriate, and also that we could try to make sure that those lows aren't too shocking as well.
Mhm. Okay. Does having had a previous unassisted pregnancy increase or help your chances of IVF success? So it sounds like this question is coming from maybe a secondary infertility.
Yeah, again, it all depends on the individual details. I met a patient today that had 4 successful pregnancies, but her most recent delivery was over 10 years ago.
Mm.
So that does give me a tremendous amount of confidence of saying, yeah, your ovaries have been very successful in the past, but here's why we need to update some testing to see what your ovaries are capable of doing today. And so this is why we have to individualize our recommendations, because yeah, I might have more confidence than someone that's the same age as that same patient today, because we know her eggs have worked in the past. But sometimes, the past doesn't actually predict the present. So it has to be individualized recommendations to each person's unique situation.
Which is like a lot of things in our
Exactly,
field.
but the reality is it's relevant data, and it
Yep.
should be factored in to the unique plan that's created for that particular patient.
Absolutely. Absolutely. Let's see. So you mentioned this a little bit before, but when to stop breastfeeding prior to an FET for a sibling. You had talked
Yeah.
about there's a waiting period, and maybe you can talk a little bit more about why you can't breastfeed while you're prepping.
Yeah, the thing that's important to realize where breastfeeding developed. A lot of people, almost imagine that the idea of breastfeeding came about, with some hippies in the 1960s. And the reality is it goes back, millennia ago. And then the point is that, in a woman that's breastfeeding her baby, she's providing a certain amount of calories and nutrients for that baby. Okay. At the same time, trying to make sure that she's maintaining enough calories and nutrients to support her own health, so that she's going to be around to raise that baby. Now, what happens in modern times is that babies start to get additional calories and nutrients from other sources, and so if someone starts the process of giving formula or solid foods or other things, what happens is that baby's needs drop. And as those needs drop, a woman's brain is sort of monitoring how many extra calories and nutrients are available. And that's what'll sort of normally signal when someone's ready to start even thinking about carrying another pregnancy. So when a woman starts having menstrual cycles again, because someone that's breastfeeding entirely and not giving any additional calories is usually not going to have a menstrual cycle for at least 10 or 11 months.
Mm-hmm.
And that's her body's way of saying, you know what? You don't have enough extra calories and nutrients to support your next child yet. And so listening to the body's natural signals, when does the menstrual cycle return? That's the first clue, because I have a large percentage of people that are what sometimes is referred to today as comfort feeding. If someone's only breastfeeding around the time of nap or bedtime, but the baby's already getting most of its calories from another source, you could continue with comfort feeding and actually start the plan for the next pregnancy. But in those situations, a woman's typically having regular menstrual cycles on her own.
And I think, some of the medications that are used as well to prep for transfer, we don't necessarily want to be passing along, right? During the breastfeeding
and
process.
again, this is an individualized issue, because most of those medications could never even enter the breast milk and therefore never even affect the child. But that's always been a theoretical concern in the past. But luckily today we've got sophisticated data to know which medicines pass in the breast milk and which don't. Another important point for those of our patients that are trying to provide some immunity to their babies, there are healthy antibodies, including antibodies against COVID-19 that are passed in the breast milk. And so again, breastfeeding does provide some ongoing protection for the baby against different infections, whether it's flu or COVID. And that's one of the many reasons that we do recommend vaccination and booster against things like flu and COVID-19.
Yeah. We have one more question, and then I think that's a good transition to we did get some questions about COVID. So this person mentioned that they're just intimidated by giving and taking the medications and the hormones, and are they really that bad? You read so many things about how, you know, horrible the hormones can be. And then how long is that? How long are you usually on those hormones?
Yeah, and again, you know, the thing to keep in mind, nobody really writes or passes or forwards, you know, that they're feeling great, you know, and this happens in all aspects of healthcare. It doesn't matter if you hear about pregnancy, everyone talks about the people that are sick with morning sickness, so much so that I could tell you that my own lovely wife felt like something was wrong because she didn't have morning sickness. You know, and the reality is it's great to not have morning sickness, but everybody is so used to hearing stories about the negatives that they don't realize that those are the exceptions. But for people that are experiencing symptoms, those symptoms can be very bothersome. And that's why those symptoms should be listened to. And there's usually different ways of trying to minimize, you know, the symptoms someone's experiencing. Bottom line is, as a man in women's healthcare, one of the things I learned many years ago is to listen carefully to symptoms and to give advice individually. And one of the things I've learned over, you know, my 27-year career now is that people that have a lot of symptoms naturally are the ones that might experience more symptoms when going through treatment, because that tells me that that person has more symptoms from their own natural hormone fluctuations. And so we're going to make those symptoms a bit worse, you know, because we're creating even more dramatic hormonal shifts, but we have ways of supporting people through that. Whether someone's having symptoms naturally, like premenstrual syndrome, there's amazing treatments for that. But not everybody has PMS or has PMS bad enough to need any intervention. And similarly, we can offer relief for people that are experiencing bad symptoms during treatment as well. But the other thing that's an important, you know, opposite side of the same coin for people to realize is people that have more symptoms during treatment should also prepare themselves, because they're probably going to have more symptoms in early pregnancy. You know, and one of the things that you know, Erica, is that I've written several books that were published by Random House, including a book on pregnancy. And my, you know, theme going through all of these books is two words: symptoms matter. And we should pay attention to people's symptoms. And first of all, explain to them what's causing those symptoms. And secondly, what things we can do to try to offset and improve their quality of life without compromising their care. And that right there should take away the fear that that patient was expressing. It's a fear of the unknown, and the reality is science has provided us with a lot of opportunity to reduce that fear with data. And we can use that data to help people through what would otherwise be bothersome situations, so they don't have to just live with it or tough it out like someone else may have experienced.
And you know, the egg retrieval stimulation phase is 10 to 12 days on average of giving those injections. You know, those symptoms may persist, you know, a little bit after the egg retrieval, but that's kind of an average 2 weeks. That it depends on the protocol, of course, but you know, that's about average. And then, you know, depending on the protocol that's used for transfer, once you get there. But there's, like Dr. Greene said, you know, definitely options for management of those symptoms.
And this is also why we have a team approach, because the nurses know a lot of the easy management tips for the symptoms, but then they also know how to reach out to our mid-levels or to those of us that know how to manage and intervene with specific symptoms if someone's having something that's above or beyond what's typical. So all we need to do is hear that there's a problem, and we usually have more than one potential option for solution.
Yeah, no need to tough it out just because somebody
No
before you
extra
did.
for that. No one's going to give you a cupcake for toughing it out.
Right. All right, let's do this last question and then we'll jump over to some COVID questions and wrap it up. But can you talk about exercise during IVF? I know, when I first started as a nurse, it was very minimal, and I think that the recommendations have changed.
Yeah, again, it's based on data. Keep in mind, I could tell you, for instance, over my 27-year career, when I first finished my training in 1995, and I'm not even making this up, the official recommendation was women were supposed to walk no more than 3 to 5 miles per week. Okay. And so women were discouraged from exercising well into the 1990s during pregnancy. And then ultimately, things have been modernized multiple different times, so that now women are told to exercise no less than 45 minutes per day, especially if they're not used to being physically active. So the reality is, our current data has given us better recommendations that, again, to a certain degree should be individualized. But the reality is to a certain degree, it's moderation. Studies have shown that excessive exercise, which has been looked at as being different for different types of exercise, can definitely decrease success rates. I could tell you, I've had some, quote, extremely healthy, competitive, marathoners and triathletes that are so healthy by, the endurance standards that they can't conceive naturally without something like IVF, because their body is more trained towards movement, not trained towards supporting a healthy pregnancy. And so sometimes we have to retrain the body. And the reality is exercise is good. Too much exercise, not so much.
Moderation. Okay, let's talk COVID for just a minute. Should you wait to transfer an embryo after having COVID?
Again, the thing that we're learning most importantly is not the presence or absence of COVID, but really the presence or absence of symptoms. And what we're learning is, as this virus continues to shift, that some people are finding that they're completely asymptomatic. We don't find that there's any data that says that somebody that should be testing if they're asymptomatic. But if someone is symptomatic, doesn't matter if they're having symptoms from the flu or symptoms from COVID or symptoms from some other severe infection. People that are symptomatic should not be trying to get pregnant at the time that their symptoms are peaking. And so, again, we're learning that as this virus continues to shift, even though a lot of people are talking about testing, we're focusing more these days on symptoms, because we know that an asymptomatic person probably has no greater risk based on all the available data.
Okay.
And the reason I say probably is we're recording this right now in mid-January, and we're currently dealing primarily with the Omicron variant of COVID, but the Delta variant, which was the previous iteration, had some more concerns. And the version before that, we had even more concerns and less data. And so I'm basing my current recommendation on what we're dealing with in mid-January of 2022. And we don't know what to expect, for February or March or beyond.
Sure. And I think that leads into the, the next question is, is it safe to start IVF in a few weeks, worrying about canceled cycles? And, it's kind of, well, we wish we had a magic, magic ball to tell us that you're going to be okay and your cycle's not going to be canceled. But again, it goes back to, like you're saying, symptoms and hard.
And in this, because for this in particular, it not only goes to symptoms, but it goes to behavior. For someone that's going through a cycle, I definitely recommend being cautious. Wearing a mask, preferably an N95 mask, avoiding public gatherings, because if someone becomes symptomatic from flu or from COVID, they're going to be canceled. And so one of the best ways to avoid cancellation is by moderating your own behavior and trying to reduce your own exposure. Because if you reduce exposure, you reduce your chance of getting any of the infectious things going around now, whether it's, flu or COVID, or who knows, maybe there's going to be a chickenpox outbreak in the neighborhood. That also could be a reason to sometimes cancel a cycle. And so we're learning that our individual behaviors gives us back a certain degree of control over our own destiny.
Okay. Do you have anything else you wanted to say about COVID? We didn't have a ton that was, specific to that. I think you covered a lot of it. But if there's anything else.
I think the thing that we're learning is that we're in the phase of this, pandemic, that it's shifting to becoming more of what we call an endemic infection. An endemic infection is something comparable to the seasonal cold or the seasonal flu that tends to come around every now and then. Okay. And, what we're learning is, probably if this continues to evolve in the same way that it's been, we're going to be basing our recommendations more based on symptoms rather than based on test results. And again, one of the powers of vaccines are that it could reduce your chances of getting symptoms and also reduce your chances of transmitting it to other people in your own circle, like your grandparents or your unvaccinated children or close friends.
Okay, great. Well, I'm going to share one last screen just because we did have someone ask about cost comparison between clinics in the area. This particular slide does show kind of, it's more than just cost. I think there's additional, you have to kind of compare cost versus success rates, right, Dr. Greene? So it's not just about, this
Exactly.
is the highest, highest cost, but how does that correlate with how successful the clinic is, and vice versa? Even if it's a low cost treatment, what is that low cost going to get you?
Well, exactly. I saw a patient just today, that basically I saw her a year ago, and I said, "What's happened?" She said, "I went to a low cost center. We tried 3 times, it didn't work, so we're back." So basically they ended up spending more money than they would have spent with one try. And that's why you got to look at not only what is the cost, but what is the chance of a live birth at the center that you're considering.
Great. So yeah, I think that kind of, covers that for now. And then, yeah, if anyone needs, any further assistance, I left my email in that chat box. So feel free to message me directly. This is the main office phone number here if you want to call to schedule an appointment, or reach out to me and I can help schedule your visit as well. And we will be posting this recording. So if you want to kind of refer back to it, follow us on social media. I will post where you can find it.
Thank you.
All right. Thanks, Dr. Greene. Take care, everybody. Thank you.
Bye now.